My name is Joyelle Sudbury, and I am the Chief Quality Officer and Vice President for Quality for Cedars Sinai Health System in Los Angeles. I'm very pleased to be joining you all today and to be asked back to this wonderful conference to share some of our lessons and things and insights that we've learned in our quality program over the many years. So today our focus will be on 3 elements of improvement work that sometimes don't always get the attention that we think are really important. So our agenda today is to really look at kind of an overview of the performance improvement work that so many of us are involved in, but really focusing on the importance of project structure, performance improvement tools, and project examples of more advanced PI tools and some examples. And then sustainment, which is often the hardest part of our work, and frankly is probably the stuff we want to do the least of because it requires kind of some time and attention after we've kind of moved on to other projects. Next slide. So first, just as a foundational item, there's a few kind of conceptual documents that we've put together to really talk about our quality program that I just wanted to start off as kind of a basic orientation. One is what we call our quality construct, which really has 3 elements. And if you start at the bottom, is that you have to have the infrastructure to work within kind of the quality program and how is that supported. Then there are systems, different quality systems within your organization that really kind of manage and oversee kind of quality as an outcome in the organization. And then there's the accountability and oversight at the very top. And that function is also responsible for assuring that systems are prioritized, as well as assuring that infrastructure is in place. The next conceptual document is what we call the 3 questions that we believe every quality program should really be able to answer, and this should be transparent all the way up through your governing board. Is the 3 questions are: first, how do we know how we're doing? So how do we monitor and gather and surface our opportunities? How do we focus on when we have all of these opportunities? There will inevitably be more than what we can possibly kind of get done all at the same time. So how do we use analysis and prioritization to really assess which ones need the most of our attention for the time period in front of us? And then finally, how do we improve? So how do we assure that we develop goals and projects that are really aligned with what the organization wants to achieve as a whole? And then again, sustainment. The next conceptual document is just an annual goal development process, which really uses the 3 questions around how we know, focus, and improve to gather together all of our potential opportunities and then do some deep analysis before choosing which ones to kind of focus on an annual basis. And finally, it's really talking about these terms and talking about quality improvement projects using some of the same language. So what typically happens is people use the word goals or metrics or targets, and they use them interchangeably. And so what we've tried to do at Cedars Sinai is to establish a very clear language use so that we all know what we're talking about when we refer to these things. And for us, goals are, what are we trying to achieve kind of overall at a broad level? The metrics are the specific measures that will tell us how we're doing and how, if we're achieving where we'd like to go or not. And so these are very precise, and it's about the things that we actually have control over. So we really want to measure that kind of precision. And then for what populations of patients are we really trying to narrow in on? And then finally, targets. So how much improvement do we want to make and by when? So these are sort of the 4 conceptual documents that we tend to show as kind of an orientation to the way we think about quality. Next slide. So when we think about meaningful improvement work, there's really 3 critical elements that typically are not talked about too much when you talk about kind of a quality improvement program. So there's a lot of different approaches and tools available, and I'm sure many of you have been exposed to lots of different tools that are out there and probably trained in a lot of them and have applied a lot of them. But we're really going to talk about 3 elements today that are often overlooked. One is the structure of the project. And that includes committed people, time, leadership, and to talk about sort of the prerequisite of project structure. Number 2 is the details of maybe some more advanced performance improvement tools including those that have been successful, and also being able to use different tools from different methodologies and really kind of package that with the overall problem that you're trying to solve to make sure that it's well suited for the leaders that are involved, the environment that you're in, sort of the ecosystem maybe of a department or an organization, and really pairing that well. And 3 is the element of how organizations sustain performance. And as I mentioned before, this can be the hardest part, but also something that we sort of ignore at our own peril. Next slide. So the importance of project structure. So we sort of talk about this using the analogy of the house. So when you're putting together a project, it's like putting together kind of the skeleton and the core kind of stable parts of a house. And we really believe that there's 5 elements that are included in that you would want to make sure that you've lined up and have very clear understanding of before you launch a project. One person, one passionate person, one data analyst, one project manager, a few people come together is not enough to launch a successful project. You really need to make sure that you have these 5 elements. And we're going to go through each one. Next. So first is leadership prioritization and engagement. So these are some questions that we would want to ask ourselves if we have these things in place in order to launch a project. So do we have the data and materials to support making this a priority? So have we made the case with leadership and broadly to really understand that this should be a priority for the organization? Secondly, do we all agree that there's great value in actually committing to this improvement work? So it's great if everyone thinks, yes, this is something that we should improve, but if they also have in mind 30 other things that they think that we should improve, that's a problem, because that may be too many things for the organization to actively kind of work on improving simultaneously. And then third is, are we aligned with organizational priorities, and can we anticipate competing interests? We all know that there are competing interests for time and attention of leadership, and that is always going to be true. So can we think about the details of this project and how they might overlap or actually conflict with other projects that might be going on? And how can we proactively plan for that and assure that leadership understands that? Number 2 is knowledgeable people. And this is really into 2 buckets. One are the guides and facilitators for the actual work. So the actual work of leading, designing, and driving and managing the project. So you need performance improvement professionals who are analytic, collaborative, that are humble and really can listen and understand problems and being very open to what we might learn and find. They need to be experienced in applying tools from lots of methodologies and understand how to use different tools. And there needs to be a set of project management skills involved to really assure defined timelines and deliverables across the course of a project. And then secondly, around the people part, is you got to make sure, obviously, that you have the right stakeholders involved. But secondly, is that you need commitment from significant partners that might need to be involved. So if you're working on something that you anticipate will have to involve, for instance, something to do with your electronic medical record, do you also have the commitment and the investment from your IT department to make sure that it is also a priority for them as they kind of move forward? Because we all have to kind of be in this together in order to make a project successful. Next. Number 3, data and measurement capability. And I can never kind of overemphasize this one enough. We have to ask the question, do we have available, timely, and reliable data to understand the problem and the potential impact that this problem has? So whether we have hypotheses as to why there is a problem, there's general curiosity to try to understand the factors that go into it, the creativity and trying to figure out how to measure the particular interventions that we'd like to start. And then also considering all the various perspectives. We have so many different types of clinical caregivers and people that are involved in processes. So do we have data available on a timely and reliable basis so that we can actually define the problem, its impact, and figure out how to measure our improvement effort? And then secondly, are those data points that we might want to be kind of interested in tracking, are they truly measuring the factors that we can control? I'll give you an example. typically when people talk about readmissions to the hospital, which is something a lot of organizations kind of struggle with, is that if someone's readmitted within 30 days of discharge, there are many, many, many reasons that someone might be readmitted. But hospitals are particularly looked at, especially in the United States, for how that readmissions are essentially the fault of the hospital. The hospital must have done something that caused that person to be readmitted within 30 days. And when you really look at readmissions, there are so many factors that have nothing to do with the hospital care that may be entirely personal to someone's life. There are many, many factors about why someone might be readmitted and that a readmission might be entirely appropriate. So we don't want to measure readmissions. We want to measure the elements within that we believe that the hospital has some influence and control over. So that's just an example of kind of the precision of measurement. And next, number 4, visibility and accountability. And again, this one is critically important because you need a venue to routinely present your work, and it needs to be visible and continually reiterated as an organizational priority. And secondly, is that the executive leadership that would attend these venues of meetings need to be invested in the success of the project, and even more so, one step further, be prepared to assure accountability of project progress. If you don't have invested and engaged executive leaders, then they're not going to ask those key critical questions to assure that a project is moving along and not lagging behind or underperforming. And finally is shared language. And as I mentioned in sort of our conceptual foundational documents at the beginning, do we all understand the problem through data and contextual data visualization? So not just anecdotal pieces, even though those are very important and powerful, but actually understanding it through the story that data can tell us and how we visualize that. And then secondly, the language that we use at Cedars Sinai is we've really, over the years, kind of determined that we needed to specify the definition of what a goal, what a metric, and what a target is. And once again, goal is what we're trying to achieve. Metric is how are we precisely measuring what we think we can actually improve. And then targets is how much do we want to improve and by when. And that precision, we believe, really allows us to get more specifically into the improvement work rather than kind of broad strokes. And so these are really the 5 elements that need to be considered when you're thinking about project structure, because the lack of any one of these or several of these could mean that a project kind of starts, stalls, stops, and may have problems along the way if this isn't kind of set up as your sort of skeleton for your project structure. So now I'd like to introduce Katie Gurvitz. She's our Executive Director of Affiliate Quality at Cedars Sinai, and she and I work very closely together. She is going to talk a little bit more about some more advanced performance improvement tools and use some project examples about how we use these different tools and in different ways across our organizations. Katie?
Thank you so much, Joyelle. It's an honor to be with you all today. I have the honor of speaking about performance improvement tools and project examples. So Joyelle's given a fantastic background in terms of project structure and some of the key components that are critical for success. And what I want to do in this next little bit is just discuss some of the tools, and then also even more specifically sharing a few examples so that you can see the use of the tools in sort of real life practice. So with that, as Joyelle mentioned, I'm sure that many of you are trained and exposed and have applied many of the performance improvement tools. So just to share a few, again, this is by no means comprehensive. There's PDSA, Plan, Do, Study, Act. There are project management methodology tools which help to frame the project. Statistical process controls, which sort of dive into common cause and special cause variations so that you can understand whether or not a process is truly being impacted for something that is a trend versus something that's special cause. And then a root cause analysis, which really allows you to deep dive in a retrospective manner to better understand and ask the question why, and get to the root of the problem and understand it more in a thorough and productive way. There's FMEA, which is sort of in contrast to the root cause analysis, is a proactive tool. So failure modes and effect analysis that allow you to identify high risk processes and help to plug any holes that you anticipate, knowing that there is high risk and high potential for error. Six Sigma, which really is focused on reducing defects and is most heavily utilized in high volume processes. There's Lean, which is focused on eliminating waste and optimizing efficiency. And then there's human-centered design, which really is intended to focus on the human need and applying the tools necessary to get to the root of the challenge, again, with the focus of the humans at the core center of what you're trying to achieve. And with all of these tools, the critical component is around packaging these tools together so that you're applying the right tools at the right time to the right problem, with the humans leading the work, with who have the tools at their fingertips to make sure that everything is applied at the right time and in the right way. So it's really around packaging the tool, the problem, and the humans leading the work to make it successful. So with that, we're going to dive into a couple project examples. So the first one we're going to talk about is human milk administration, and we're actually going to walk through a very high level example of an FMEA and some of the processes that helped us to yield interventions and better apply tools to solve this problem. So like I mentioned, the FMEA is really a proactive tool that's used to plug gaps where a process might fail and assess the impact for these failures to put those hard stops in place. So the three questions you want to ask are: what could go wrong? Why did the failure happen? And what would the consequence of each failure be? So for this project, just like we always do, we set up a project charter that helped us to frame the project, get all of the leaders and participants on the same page, and really frame the challenge. So the problem statement that was identified is that human milk can transmit infectious disease, causing potential harm to highly vulnerable patient populations. And then we established, as Joyelle walked through, the goals, the metrics, and the target so that we had an established framework, shared methodology, and terminology to solve this challenge. And so, as you can see, the goal was to evaluate the human milk administration, which was a high-risk process. The metric was to identify the potential failures for providing the wrong milk to the wrong infant. And then finally, the target was around completing it and then applying those interventions. And as you can see, it was a multidisciplinary team that was involved in this process. So we went through the process. We looked at a couple key areas. So human error, time, broken equipment, and indicator malfunction. And as you can see, there were many elements beneath each one of these that sort of emerged as potential failures. And ultimately, it led to 4 key identified areas of focus. So these were the interventions that the team was able to put in place going forward. So this was a great application of the tool that involved so many different members of the community more broadly and helped to solve this challenge that was at hand. The next project is a little bit of a change because it's utilizing human-centered design and data-driven design with precise intervention. So with this project, and like many, and I'm sure you experienced this as well, is that this has been an iterative project throughout many, many years, focusing on challenges within the ED, and the focus has shifted across time. And what I want to do today is just focus on the work that we're doing in 2021, which is focusing on ED throughput for the behavioral health population. So the data-driven component was really important here because we wanted to understand what the population of the psych-related encounters were within the broader population. And so again, with multiple data slices, we were able to identify that it was 9% of our overall encounters were related to psych-related issues. And again, we used a broad array of tools to better understand what this looks like. And what we learned is that the psych patients stayed in the ED 3 times longer than the non-psych population. So this was a huge challenge for the ED staff because it created additional work, additional challenges, and added focus that they really wanted to help to prevent going forward. So a variety of tools were used in this process, and the first was the project charter. So we talked about that briefly already. And then we used human-centered design to make sure that we better understood, and I'll zoom in a little bit here, the journey. So what this shows is that we were able to shadow both patients and staff and really understand both the emotional and physical journey of what the care providers experienced with the psych population. So this was a fantastic human-centered design tool that really helped us to better understand the challenges they were facing. We also used a Pareto tool because there were key high utilizers that were taking up a large volume of this population, of the 2,500 patients we had identified. So this again helped us to narrow our focus. And so several interventions were launched based on all of this information we learned, and it's an ongoing and current project that a multidisciplinary team continues to dive into and helps to reduce the challenge and improve flow in the ED. And with that, I'll hand it back to Joyelle.
Thank you so much, Katie. That was a great example from one of our smaller community hospitals. And so you can imagine the different challenges we have with different size facilities that I'm sure all of you probably face as well. So the last section here is around sustainment, which I just have mentioned before is often the hardest part and also the part that no one really wants to pay attention to. So next slide. So one of the ways that we talk about sustainment is by putting it in a dashboard, because we need to do several things to assure that we're sustaining our performance. We need to organize and track and monitor our performance, but also put some set criteria down when we're closing out a project about what control would really look like. So next. So in this, we created kind of a template that you see here on the left with an actual project example here. And so we've come up with what we do for every project that we're closing out is we develop what is the sustainment metric that we actually want to measure. How do we kind of make sure that we get that performance, regularly reported? And then we created a control plan threshold. So at what point, based on all of the data and the information that we knew from this improvement journey, would there be a threshold for determining if this process is no longer stable and is actually out of control? So we established that threshold at the very outset after kind of closing a project. What would control look like, and when would we know as the trigger that we needed to do something? And then beyond that, what's the response plan? What are we going to do if this process goes out of control? And so on this template here, you'll see there's the metric, there's actually months of data, and then there's the documented response plan, the factors, and the next steps. And actually in this example, and you'll see on the next slide, if you can go forward. Oh, sorry, here's the details of this. And so you can see there's a control plan threshold for each one of these. And next. So the next thing is we actually do and develop control charts. So we look at our control limits, our upper and lower control limits, to actually see where the process kind of stands. And as you can see kind of in this first part, this is from September 2020 to February 2021. And this has to do with documentation of advanced care planning. And so a physician order for life-sustaining treatment. And as you can see, we had a process that really was in control from September through about maybe April. And then we started to see the performance to drop below the lower control limit. And then we noticed that was that seemed to be a complete pattern as we go forward. And if you continue on that line, the next major dip happens in December and in January. And in this case, it was really important that we were monitoring this because this is actually when we had several COVID surges. So this kind of lines up very well with those examples of when the organization is focused on other things and needs to be focused on kind of adapting the care plans and kind of the strategies for caring for patients, that these things can actually happen over time. So we were monitoring this and we were able to trigger our response plan. Next slide. And so here's an example. We track our projects for 5 years after we've closed out a project. So for 5 years, we track the sustainment metrics. We track the performance either on a monthly or quarterly basis. And then we keep an eye on that control plan threshold to see if we have a problem and we need to get the group back together again to assure that there is stability in the process. So if you look across this dashboard, it's very hard to read, but it's very small. There's the metric, there's each month of performance, there's the actual control plan threshold, there's the response plan that's planned, and then there's the performance as to whether or not we need to bring something back together. Next. And so what we've learned kind of over time when doing the sustainment work is that focusing on that long-term stability after the organization's really shifted to other focus areas is really important, or we end up doing the same projects every 2 or 3 years. And a way to really kind of put a stake in the ground to know where your performance is so that it's not a kind of a squishy assessment as to where you are is that you set those control plans and those thresholds kind of right at the end of a project so that you actually have a way to measure how far off your performance may have gotten from the goal. Tracking those metrics for, I would say at a minimum of 3 years, but we, as I mentioned, we do 5 years, and we've actually learned a lot from that. It really gives you a sense as to whether or not your interventions can be kind of what we call drift proof. We don't want our performance to drift. And so is it really drift proof, and has it been hardwired? The other thing that's sort of the unpopular message here is that this takes a lot of time and effort to kind of put this much attention on sustainment. So it definitely takes time and effort, but we believe it's worth it to make sure that there's stability in a process long term. And that without sustainment, as I mentioned, we all kind of keep coming back to the same problems over and over again. So final slide, or last slide here. Key takeaways. So just to summarize for Katie and I around our key takeaways here, we really talked about 3 things. One is project structure, which is really the actual kind of elements and skeleton of kind of the house that you're building. And the key takeaways there is that you've got to do this broad surveillance to really understand where your opportunities are. You need engaged and aligned local leaders to drive meaningful change. And you need a disciplined focus and approach on the most important priorities in venues and with leaders that are very invested. The second is around kind of using more advanced PI tools, which is sort of filling out your house. It's the tools that you use to really make that improvement work. And that data is essential to that. Measurement is essential to that. And that the tools that you use is not one size fits all. So you can't have one methodology that you use and you look at every problem through that one lens. We really believe in a broad toolbox, and therefore you need professionals who really understand how to apply different tools and package them with the right people and situations. And then finally is sustainment. In order to make sure that your house is standing 2, 3, 5 years later, you really need these tools to track and monitor. What does sustainment of performance look like long term? And how can we make sure that these improvement efforts were worth the effort and are still in place many years later to continue to provide, the excellent care that you were striving for at the outset of the project. And I believe that's our final slide. And we just want to say thank you so much for having us and for inviting us to be part of this. We welcome questions or opportunities to connect or network. And we hope everyone has a great rest of their day. Thank you so much.
Thank you for having us.